Мені повідомили організатори, що ми, в принципі, мали би завершити нашу частину, але все-таки в нас залишився борг. ПьоТр ВІЛАНД готовий прочитати нам у записі лекцію і просили це зробити до обіду, тому що після обіду у нас буде інша програма. Тому я дуже прошу включити лекцію ПьоТра ВІЛАНДа. Ми будемо доєднуватись, дивитися і за той час будемо дискутувати про те, що будемо чути. Дякую вам.
Thank you for the invitation. My name is Piotr Bilan. I'm the head of Department of Rheumatology and Internal Disease in Wroцлав, and I'm from University Medical in Wroцлав. The title of my lecture is Difficult to Treat Connective Tissue Disease, Resistant to Corticosteroids. So, this histopathological concept of connective tissue disease was proposed by American pathologist Blau Klemperer in 1942. And that time, 6 diseases were termed as classical connective tissue diseases, as rheumatic fever, rheumatoid arthritis, polyarthritis nodosa, systemic lupus erythematosus, systemic scleroderma, and dermatomyositis. Later, this list was modified and broadened of some other disease. Among them, I think that the most difficult to treat the group of connective tissue diseases are idiopathic inflammatory myopathies. So this will be the topic of my lecture. So we have some EULAR recommendations for the treatment of such connective tissue disease like systemic sclerosis, which was published in Annals Rheumatic Diseases, systemic erythematosus, published in 2019, large vessel vasculitis, published in Annals Rheumatic Disease 2020, and rheumatoid arthritis was published this year, and also this year will be published ANCA-associated vasculitis. So this is the disease which are well described, but as to the idiopathic inflammatory myopathies, it's a problem. It is a heterogeneous group of disorders in which chronic inflammation of the skeletal muscle leads to the muscle weakness. It's a common feature of these disorders. And we have some recommendation from EULAR, which were published in 2017, and this recommendation were concerning on classification criteria for adult and juvenile idiopathic inflammatory myopathies and the major subgroups. But it was only recommendation about classification criteria, about diagnosis, but there was no EULAR recommendation about the management. I know that it's the big problem because it's not one disease, there are many diseases, and you have seen that there are 5 clinical subsets of idiopathic inflammatory myopathies, and this division is based on clinical, histological, immunopathological features, and some autoantibody association. So we can divide dermatomyositis, polymyositis, necrotizing autoimmune myositis, we have antecedent syndrome overlap, and inclusion of the myositis. I would like just to show you a short explanation of each of these 5 clinical subsets. Start from dermatomyositis. It presents with skin manifestation like erythematous rash, some changes like periorbital heliotrope, which accompany or sometimes preceding muscle weakness. It's very characteristic picture in capillaroscopy as dilated capillary loops at the base of fingernails, and in the physical examination we can see cracked palmar fingertips, called also mechanical hand, and there are also subcutaneous calcification, especially in children. Sometimes dermatomyositis is limited only to the skin, so we call it amyopathic dermatomyositis. But if we perform biopsy in this patient, this picture may reveal typical lesion for myositis. So this disease may overlap with systemic sclerosis and mixed connective tissue disease. And we should also remember that in adults, the malignancy risk is about 15 to 20%. So this patient, when we will diagnose the patient with this diagnosis, dermatomyositis, should have careful observation, especially not only on the one, but especially we should monitor them regularly 3 to 5 years from the onset. So the second, polymyositis, it is rather rare clinical subset of inflammatory myopathy. Why? Because usually this patient we can define as polymyositis when we can exclude some other disease, subset of disease like inclusion body myiasis, necrotizing anti-inflammatory myositis, or inflammatory dystrophy. So we should exclude this subset. And the best definition is maybe just to say that it is subacute proximal myopathy in adults who do not have such signs like rash, they have no family history of neuromuscular disease, they have no exposure to myotoxic drugs, they have no involvement of facial and extraocular muscles, they have no endocrinopathy, and it's not clinical picture of inclusion body myositis. The third, necrotizing autoimmune myositis. Now, some authors describe this subset that it is the most common of inflammatory myositis subtype. It starts all acutely with the peak of clinical activity and very over days and weeks, and it's mainly the patient is with very severe muscle weakness and level of CPK are very, very high. So sometimes we can also describe in this patient rhabdomyolysis. Or they have the course of disease could be also subacute. Sometimes it may occur after viral infection, may be also connected with cancer or immune checkpoints inhibitors administration. But it is very rare connected with administration of statin for years. Most of these patients have antibodies against signal recognition particle SRP or HMG-CR. The next anti-synthetase subset, this patient, we observe in this patient myositis, interstitial lung disease, arthritis, which is the form of subluxation of interphalangeal joints, similar maybe sometimes to the patient with advanced rheumatoid arthritis. We can see also mechanic hands, and they have also renal phenomenon, and as to autoantibodies, they have anti-synthetase antibodies, mainly anti-Jo1. And the last one, it's a little bit quite distinct myositis, and it is treated as the most common and disabling myopathy above the age of 50. It starts in centers over years. Sometimes it's suspected when a patient with presumed polymyositis did not respond to corticosteroid treatment or other demands. The clinical picture is early involvement of distal muscles, especially foot extensors and finger flexors, atrophy of the forearms and quadriceps muscles in the physical examination, and they have frequent falls due to quadriceps muscle weakness. And more than 50% of patients we may observe dysphagia, and in muscle biopsy they are not exactly myositis, but they are present rim vacuoles. So, to date, there are no specific therapeutic guidelines in Europe which are widely approved for the treatment of inflammatory myopathy. Usually, these patients, they are treated with Glücocorticosteroids and conventional synthetic disease-modifying anti-rheumatic drugs. Some patients are treated with rituximab, or some patients are treated with intravenous immunoglobulins, or subcutaneous immunoglobulins also. But in 2022, there was recently published guideline by the British Society of Rheumatology, which I tried maybe just to show some of these points are very important for treatment. So this is the authors, and this work is looking not only for adult, but also for pediatric and adolescents patient with idiopathic inflammatory myopathy. I would like that mainly maybe just to show you the guidelines for adult inflammatory myopathy. So it is form of this recommendation. It's with the questions and with the answer in each point, which are very important. So the most important questions is how we should skeletal muscle inflammation treat. So the first point, high dose glucocorticoids should be used to treat active muscle inflammation at time of treatment induction, and it was 100% of the authors maybe voted for this. As to the details, we can give this glucocorticoid in the form of oral form. So oral prednisolone at a dose of 0.5 to 1 milligram per kilo per day. Usually it is about 40 to 60 milligrams. It's recommended. And it's also possible to give them intravenous methylprednisolone, especially when they are concerned about gastrointestinal absorption. This use of this intravenous form may allow increased therapeutic effect, and it is less toxic compared with oral glucocorticoids. But when we gain response, then we should taper this oral prednisolone as quick as it's possible, rather slowly. And sometimes we start with glucocorticoids, also disease-modifying anti-rheumatic drugs, because maybe we try to reduce muscle inflammation, and also we want to reduce steroid dose and achieve clinical remission, if it is possible. So among these MADs, there are rather broad list. It's methotrexate, azathioprine, tacrolimus, cyclosporin, and mycophenolate mofetil. Could be considered for the treatment of the active myositis and long-term maintenance of disease remission. If it not works, or it's not sufficient response, then we may think about intravenous immunoglobulin as a treatment of severe or refractory muscle inflammation. And we should remember also not only about pharmacology, but also about exercise programs, which is very safe, and this patient should be monitored by the specialist physiotherapist and all specialists of occupation therapists, just to improve quality of life and, of course, to maintain function. The other possible drug when we have not response maybe to corticosteroids or MAD is rituximab. It is treatment option for refractory myositis, and we should remember, especially in such situation like juvenile onset disease, patient with a positive myositis autoantibody profile, and the patient with lower burden of disease damage. We should also think about cyclophosphamide as a treatment option for severe or refractory inflammatory myopathy. So maybe for this severe refractory muscular inflammation, we have intravenous immunoglobulin, rituximab, and cyclophosphamide. And at the end, British scientists also suggest that abatacept is to be considered as a treatment option in refractory adult inflammatory myopathy. The other question, very clinical meaningful, is how should interstitial lung disease related to myopathies be managed? So, start from adult-specific interstitial lung disease should be screened for in a high-risk patients, and in the treatment of rapidly progressive interstitial lung disease, it will be maybe found. So then we should remember about induction therapy with high-dose steroids should be considered. In this patient, we should also think about cyclosporin or tacrolimus alongside with steroids, because and also we should think about cyclophosphamide and rituximab as maybe just to treat this patient early potentially as a part of the induction regimen. So we should also screen this patient with inflammatory myopathy. So British Society recommendation are as follows. So maybe children, they don't need maybe any screening because it's not so, it's rather very rare, but we should be very cautious in adult patient because the risk of cancer should be considered in all these patients, and screening should be particularly considered in those with such following risk factors like older age and onset, male gender, dysphagia, cutaneous necrosis, resistant to immunosuppressive therapy, rapid disease onset, and some autoantibodies, anti-TFF1, anti-NXP2 autoantibodies, and negative for non-myositis specific autoantibodies. We should rather perform CT scanning of the thorax, abdomen, and pelvis, and this patient should be, this examination should be repeated maybe in the first 2 to 5 years. So those was the British Society guidelines, and in the publication we can also meet such approach of Marinos de la Cas in Acta Myologica 2020, which present how to say algorithm, a step-by-step approach in the treatment of inflammatory myopathies for each of the subset of the inflammatory myopathy. So mainly they are very common for dermatomyositis, polymyositis, or necrotizing myositis, except inclusion about the myositis. So at first, high-dose prednisone, oral or intermittent intravenous in acute cases. When we have the patient is steroid non-responsive or it's not so good response, that we should add immunosuppressive agent like mycophenolate, azathioprine, and methotrexate. If these two steps fail, then we should administer high-dose intravenous immunoglobulins. And if these immunoglobulins are not sufficiently effective, then we should consider rituximab. And if anything doesn't work, maybe then it's the step just to consider new biologicals. But of course, it's a little bit future, but we should know what is promising among new biological or other drugs. So, for example, for dermatomyositis, new biologic including eculizumab, other anti-B-cell agents, or maybe JAK inhibitors, which are registered in rheumatoid arthritis, and maybe they will be also helpful maybe in very resistant myositis. Most promising future is the drugs which are in the clinical trials, like anti-complement agents, such eculizumab, ravulizumab, and zilucoplan. Polymyositis, rather if the point 1 to 4 is unsatisfactory, then we should rather consider the diagnosis if we are sure that we confirm this diagnosis, or maybe there is some other. In necrotizing autoimmune myositis, there are similar maybe approach to dermatomyositis and antisynthetase syndromes. If there is interstitial lung disease, may also consider cyclophosphamide. So, but it's completely other approach in the patient with involved in myositis. It's rather physical therapy. We know that corticosteroids and some other immunosuppressants, they don't work. So if there is any controlled trial, we may encourage to participate the patient. But if there is dysphagia, it's worth maybe just to try maybe to give intravenous immunoglobulins. And up to now, all trials with immunosuppressant, immunomodulation agents, muscular factors have failed. Among them, despite of it, most promising was alemtuzumab, but it was in an ongoing study. So, conclusion of my lecture, that despite advances in treating inflammatory myopathies in the past years, much remains unknown. It should be made special efforts to offer more precise therapy based on clinical presentation, organ involvement, and biochemical markers. And as I start maybe with the title, inflammatory myopathies are disorders which are difficult to treat. Thank you very much for your attention.